Hello, everyone. My name is Emily Romney, and I'm the Community Education Manager with the Myotonic Dystrophy Foundation. I am so excited to welcome you to our Ask the Expert webinar today on reproductive health and myotonic dystrophy. Before we begin, a little bit about the Myotonic Dystrophy Foundation. We envision a world with treatments and a cure for myotonic dystrophy. We support and connect the myotonic dystrophy community. We provide resources and advocate for care. We accelerate research and treatments toward a cure. MDF is here to support you. We have toolkits and publications, which include resources for care providers and families. We also have support groups, which are led by trained community volunteers, and our safe spaces to network, learn, and share. Additionally, we have our digital academy where you can view hours of educational and inspirational videos by DM experts on demand. You can find all of our upcoming support group, conferences, webinars, and more at our calendar of events on our website. We would love for you to stay in touch with us. You can follow us on social media to make sure you're up to date on all things MDF and DM. You can find us on Instagram, X, Facebook, and LinkedIn. MDF is very excited for our 2025 conference in Indianapolis, Indiana from May 2nd through the 4th. Registration for the conference is open. Be sure to check out the MDF discounted hotel room block, the detailed community sessions listed on our website, and our new Sunday morning workshops. You can learn more about the conference and register on MDF's website. I also want to highlight an upcoming event. MDF is hosting a Meet the DM Drug Developers webinar with Lupin Neurosciences on November 22nd, 2024 at 10 a.m. You can register now to participate. I'd like to thank Avidity Biosciences, the sponsor for this Ask the Expert webinar. And I will now turn the time over to Erica Escartin from Avidity Biosciences for a brief presentation on Avidity and their commitment to education in the DM space. Thanks, Erica.
Thanks, Emily. And thank you to the Myotonic Dystrophy Foundation for inviting us today in this very important topic in this webinar. As Emily mentioned, my name is Erica Escartin. I'm the Senior Director of Global Patient Advocacy at Avidity, and today I'm just going to present just a few short slides on who Avidity is and how we partner with the MDF, with the DM1 community and MDF. Next slide. And next slide. At Avidity, we are truly committed to improving the lives of people impacted by neuromuscular diseases, including myotonic dystrophy, and we are also working very fast to get development of new drugs for not only DM1 but also FSHD and DMD. Next slide, please. Avidity is a company that was founded in 2013. We're a publicly traded company that's headquartered in San Diego. And we are really truly committed to bring a new class of RNA therapeutics utilizing our AOC platform. And with our AOC platform, we are looking at 3 clinical stage programs in 3 rare diseases, which include DM1, FSHD, and DMD. We also have additional therapeutic areas that include immunology. And just recently this week, we announced our new therapeutic area in the precision cardiology space as well. Next slide. At Avidity, we are truly committed to the values that shape us every day. The AVID values are about to be agile, visionary, integrated, and diverse. And that really informs our patient advocacy engagement and the way we show up with the patient advocacy community, as well as DM1 community and the other communities that we serve. We really want to ensure that we are identifying patient needs as fast as we can and also uncovering opportunities where we can educate and support each community. We want to be visionaries to ensure that we're also shaping a better future with the treatments that are in our pipeline and the potential purpose that they have as well. We also want to integrate multiple stakeholders in our initiative. So we partner with patient advocacy associations, we partner with families, with caregivers, and we're truly committed to ensure that the patient voice not only is seen and heard, but internally we drive that patient voice in all the decisions that we make. And then last but not least, but we also are committed to, include a diverse number of, patients and individuals and caregivers in our clinical trials, but also in all the activities that we are committed in doing. Next slide, please. From a patient group's perspective, in the DM1 space, we are partnering with several groups. Obviously, we have a wonderful relationship with the Myotonic Dystrophy Foundation, where we have partnered in several different ways. In the annual meetings that the MDF Association has. This year, they had 6 regional meetings, which we attended all over the U.S. We also have been fortunate enough to be in the Meet the Drug Developer series as well. And then most recently, we attended the MDF annual gala that happened in September that also correlates with DM Awareness Day. Not only is our footprint in the U.S., but we're also expanding our efforts outside the U.S. So recently, through the MDF Foundation, we had an introduction with the Myotonic Dystrophy patient group in Japan. And we are actually now developing new initiatives and partnerships and opportunities with them to not only bring clinical trial awareness activities to the Japan DM families, but also help them understand who our company is and what are we committed on doing in the DM1 space. And last but not least, we also have partnered with Eurodyma and have several interactions with them as well in different ways, such as focus groups and also just kind of providing partnership as well. Next slide. Just a really quick snapshot and roadmap of some of the key milestones for our AOC 101 program, or really Del-Zota. We're excited that this program really started in 2021, when the first patient was dosed in the Marina trial, all the way through this year, initiating the Harbor study, so our phase 3 global study in June. And just, recently receiving breakthrough designation for Del-Zota as well. We were very happy and excited that our clinical hold was also removed in October, which, didn't stop our efforts in the Harvard study or, moving on with the phase 3 study. Next slide. This is my last slide, and this is the Avidity team that's working relentlessly and tirelessly with the, for the DM1 community. And we just want to thank you for allowing us a space to be here today, and also for the partnership to really make the progress possible in bringing Del-Zota to the market as quickly as we can. So with that, I'll pass it over back to Emily.
Thank you, Erica, and thank you again to Avidity Biosciences for sponsoring this Ask the Expert webinar series and for the great work you all do in the DM space. Thank you to our attendees for joining us today from around the world. Today's program will be an Ask the Expert webinar featuring presentation from Drs. Hamel and Thornburg, followed by time for a Q&A. We do ask that you use the Q&A function to ask your questions, and they will be sent directly to our speakers. We will do our best to answer as many questions as we can. To ask questions, click the Q&A button, type your question into the text field, and click Send. You can also send questions anonymously if you prefer. Now I am pleased to introduce Drs. Thornburg and Hamel. Dr. Lorelei Thornburg is the James R. Woods Jr. Professor of Obstetrics and Gynecology and Division Director of Maternal Fetal Medicine at the University of Rochester Medical Center in Rochester, New York, where she completed her medical residency and fellowship. She is passionate about the care of people with complex disease in pregnancy, most notably focused on neurologic disease in pregnancy. Dr. Thornburg works with a number of organizations around the country to help birthing people have access to the care they need to have safe and healthy reproductive lives, including during labor and delivery. Dr. Johanna Hamel studied medicine in Germany, completed residency and fellowship trainings at the University of Rochester. Her focus and interests are neuromuscular medicines and DM. As a clinical researcher, Dr. Hamel focuses on natural history studies, disease progression, biomarkers, and transcriptomic changes. She is a co-PI of the Wellstone Muscular Dystrophy Specialized Research Center. In the clinic, she cares for DM patients. Dr. Hamel focuses on remote patient assessment methods and patient registries. With MDF support, Johanna ultimately launched REACH-DM. Dr. Hamel sees the developed methodology as foundational for expanded studies of genetic modifiers and the real-world impact of new drugs. I will now turn the time over to Drs. Hamel and Thornburg.
Thank you very much. Let me just share my screen here. Okay. Okay, very good. Well, thank you very much for having us. We're excited to be here and talk on this topic, which we are passionate about. And the topic is women's health, fertility, and pregnancy and myotonic dystrophy. And I'm very excited to have Dr. Thornburg here with me. This talk will be a back and forth conversation between the two of us because we have complementary perspectives. Hopefully we can give you a comprehensive overview. And to start off with, women's health covers a lot. It includes family planning, menopause, fertility, menstrual health, sexual health, pregnancy and delivery, and beyond that. However, it's too much to cover in one webinar. And so today we will focus on aspects of pregnancy and delivery and fertility, but we recognize all the other topics that may need future attention and that we're also passionate about studying and getting better answers to. So to give you a little bit of an overview, what we'll talk about, we will cover what is the process of IVF or in vitro fertilization. We'll cover topics of fertility, what to do before a pregnancy. We will also review a little bit what happens during pregnancy to the body in general in people that don't have myotonic dystrophy, which is important to understand when we think about, well, what is specific in myotonic dystrophy and how can pregnancy impact people's lives and how to prepare for it. And then in the end, we will conclude with the notion that more research is needed, particularly on this topic. To start with, you will hear a lot of words, and so some of them I don't use as much either as a neurologist or neuromuscular specialist, and Dr. Thornburg will help us understand those better. But IVF, you'll hear about in vitro fertilization, and she'll explain in just a second what this is. Then there's ICSI, or intracytoplasmic sperm injection, which means that a single sperm is injected into an egg to help with fertilization. You will hear of PGD, or pre-implantation genetic diagnosis, which means that the DNA of an embryo or an egg is studied before it is implanted into a woman's uterus, and that can help have a baby that doesn't have myotonic dystrophy if the couple chooses to do so. And then just for clarification, late preterm delivery is defined between 34 and 37 weeks, and preterm delivery is defined as a delivery of the baby before week 37. Just upfront, a little bit of a dictionary. And then let's take a pause, because what I want you to make sure is, as you listen to the webinar, just keep in mind the limitations of the information presented. The data is limited, the information is limited, and when we try to help you apply it to yourself and where you are in your life and how the disease is impacting you, I would highly encourage you to seek help of your doctors, including your OB-GYNs, but also your neuromuscular specialist, because, and I'm sure you've heard it so many times, but it cannot be underestimated. DM, both types are just highly variable. And so, generalizing data is always difficult in medicine, but in particular in myotonic dystrophy, where we deal with a decent amount of variability. Now, what are the other issues here with the data limitations? So I'll talk a little bit about bias because I want you to keep that in mind also in the future when you hear about certain studies or anecdotes or things that people just share, experiences they had. So there is something that's called sampling bias. And as you can imagine, if this is the whole group of patients or women with myotonic dystrophy, and then we do a survey and we ask people to respond to a questionnaire that we mail out. And a lot of the studies, which the information you will see throughout the webinar is based on surveys. And then a fraction of those folks will return it. For example, one of the studies that provided helpful information, only 40% of people who received the mailings returned them. And so you have just a small group actually participate in the research. And the question is this small group actually representing or, representative of the whole group of people living with the disease? Is this sample really, giving us the full story? And so the answer is it depends, but there is that is up to, that is unclear. Then there is such thing as recall bias, and we all experience that every day. If you are asked, well, 5-10 years ago, what kind of symptoms did you have or what complications did you have? It's hard to remember, and for everyone. And in particularly if it's survey-based or what we call retrospective, where things are studied that happened in the past and not prospective, where we kind of document things as they're happening live. So that's recall bias. And you can also imagine that certain events that people experience in their lives are more memorable than others. And those you might hear more about. And then there is publication bias. So in medicine, a lot of studies are published when they're positive in terms of a drug had an effect. If a drug didn't have an effect, often it doesn't get published as much. Similarly, if something goes wrong, people publish it more likely than if something went really well. If a person with myotonic dystrophy had a great delivery, that's not going to get published. But if something went wrong, there might be a case report. And those case reports are extremely important because they give us ideas for future studies, or they raise awareness for a problem that we need to be aware of. But on the other hand, it might skew the kind of picture that things are, severe, even because we don't see when things go well and they're not happening, they're not reported in the literature. So that's another bias. And there's more biases, but I just wanted to give you an overview of what, always keep that in mind when we talk about data. And the answer to all of this is we need more research, we need more studies, we need better studies to get better answers. With that, I will pass it on to Dr. Thornburg to go through IVF.
So I'm going to talk about IVF, and I think that bias question is one that I think is really important here when we talk about pregnancy. I think Dr. Hamel is bringing up something that's very, very specific, and I think that pregnancy is one of the places where we see the most bias in these data. So I want everyone in the room to remember that your pregnancy and your issues may or may not be represented in these data, right? So you may have more or less disease issues, you may have other things, right? Just because you have myotonic dystrophy doesn't mean you can't also have diabetes or something else that could be very different for you. So please use those, take all of our interpretations with caution. And, one example that I use with patients a lot is if I ask you what you ate on November 11th, 2021, you would have no idea, right? But if I ask you what you ate the night before you went into labor, most people can remember, right? Which is why we have all these old wives' tales about spicy food made you go into labor, right? Because people can remember what they ate before a big, important event because it's related to that event. So what happened affects how we remember something. So I think that's such an important point. So let's talk a little bit about the process of IVF. So IVF, affectionately called in the 80s the test tube babies, is where we take eggs and sperm and we put them together in an artificial environment to create embryos. And the way we do this is we have to get the eggs and the sperm out. Now, sperm are inherently easier to get out of a reproductive person, right? Because by their nature, they're expelled from the body. So we can either take ejaculate from a man and get the sperm out of that, or in the case of people who have myotonic dystrophy who either cannot ejaculate or who have ejaculate without sperms, or people who have sperm issues or testicular issues for other reasons, you can actually do little biopsies and take sperm directly out of the testicle itself. We then take eggs out of the ovary. And of course, you want to, when you go and do that, you want to make sure that you're getting more than one egg, right? You wouldn't want to just collect one. So just like going to the hen house, you want to make sure you get, a dozen eggs when you go. So what we do is we give people medications that make your ovaries produce more than average eggs in a certain cycle. And then through the vagina, we put in an ultrasound, like a vaginal ultrasound. And we use a very small needle that passes through the wall of the vagina into the ovary, and under ultrasound guidance, take those eggs one by one with that needle and remove them from the ovary using some fluid and a syringe, and then take those into the lab. Then the sperm and the egg are mixed together. We sometimes use that process that she was talking about called ICSI, ICSI, and that's where you actually take individual sperms and push them into the eggs if the sperms are not good swimmers, which can sometimes happen. But sometimes we just mix them together and let them settle down into a petri dish together. We play them some Berry White, I'm just kidding, and get them to do their thing and make little embryos. And then those embryos get graded. They get scored A, B, C, D. And the embryos that are the best looking are the ones that get returned to the uterus. In the case of somebody who has a reason why they might want embryos tested, whether that's age-related or whether that's for something that they carry in their family, everything from myotonic dystrophy to other recessive disorders to other things that could be things that they're trying to avoid having a child with, those embryos can be tested for that issue. That testing can then select embryos that do not have that condition, and then the best remaining embryos are then replaced into the uterus, typically one at a time, one per cycle, and hopefully implanting and allowing for pregnancy to progress. So you still need eggs, sperm, and uterus to make this process happen. Next slide. So this is a complicated slide, but the reason that we have it in here is because depending on which partner has MD and which partner is affected and what fertility therapies are needed can depend on what you might want to do. So if, for example, you have a male partner who's affected, or has a premutable carrier mutation, if you choose to use gamete donation, which is like sperm donation, that's one way to avoid having an affected fetus. But if they want to use their own gametes, then you can do something like IVF and then do that pre-implantation genetics and avoid having a child with that gene passed along. Similarly, with a female partner, again, if they're known to have that premutable carrier state or to be affected genetically, again, we can take those eggs, we can do that testing, and we can minimize the risk. But one of the things that's important here is that while both male and female partners are at risk for expansion and will undergo expansion of their repeats, typically with passing on the gene, women passing the gene on are at more risk for expansion than men passing the gene on. And that means that women passing the gene on through their line are at higher risk for having infants with congenital myotonic dystrophy. And that is a much more severe form of myotonic dystrophy. And so we have something we call anticipation. And so how interested families may be in using these services may vary between families. And using these services can be something that varies for not only whether or not who's affected, but also what else is going on in people's lives. If people get pregnant unexpectedly, there's then the option for things like CVS and amniocentesis. And these are testing once a pregnancy has already occurred to see if a pregnancy is affected. And there are two ways to do this. The first is called CVS, and this takes a very small piece of the placenta as early as 10 weeks. It carries a less than 2% chance, less than 0.5% chance, less than 1 in 200 of losing a pregnancy. And you take a small, tiny little piece of the placenta, which is made from the same cell lines as the baby. The baby makes its own placenta. And you take those cells and you test them for the presence of the gene in question, and then you can see whether you have an affected pregnancy. Similarly, in amniocentesis, which is a slightly different test, but we put a very, very small needle into the sac of fluid around the baby. The sac of fluid has skin cells, so just like adult humans, we leave our skin cells behind, and that's why we have to, vacuum the carpets. The baby leaves skin cells in that fluid around the sac, and we take those skin cells, we can check the genes in that skin cells for the DM mutation.
All right, we'll shift gears a little bit here, back and forth. So we'll start with fertility. And we just wanted you to be fully, for those who haven't heard a lot about these concepts, IVF and those services, we just wanted you to be aware up front because those terms will be mentioned. But shifting gears to fertility. So fertility happens in people without myotonic dystrophy. Infertility happens, or problems with fertility happens with people without myotonic dystrophy. So 8 to 12% of couples have trouble worldwide. Men with DM1, and this is not the topic here of the talk, but just upfront, men with DM1, it's been widely described that there's problems with fertility. It has been described that there's atrophy of the testis, there's reduced sperm, and that has been over and over reported that there are problems with fertility. Doesn't mean that men with myotonic dystrophy cannot have babies, not at all, but it can just be at times more challenging. In terms of fertility problems in women with DM1 and DM2. So myotonic dystrophy type 1, I call DM1. Myotonic dystrophy type 2, I call DM2. And I'll use those two colors to kind of highlight it. What is the issue with fertility in women? It's controversial. I'll give you two opinions. We'll start with the first. One study that was done in the Czech Republic studied a specific hormone, the anti-Müllerian hormone, which is a marker of ovarian function, and it declines with age. And for example, it's undetectable at menopause. It's often measured when you undergo those fertility treatments or when you undergo IVF. A person regularly seeing their OB wouldn't have that checked, to my knowledge. And but this was checked in a sample of DM1 patients and a sample of DM2 patients, and they also chose to test it in age-matched controls. So people without myotonic dystrophy that were of the same age as the people with myotonic dystrophy. And what they found is that, again, small, not huge numbers, 21 people with DM1, 25 people with DM2, but they found that there was no difference in these hormone levels indicating ovarian function in DM2. While there was a difference in DM1, they saw that the levels were a little lower in general. And they also saw that people who had really levels that were outside of the normal range were a little more common in the DM1 group. But you note that all groups, there are people who have really, low levels. And that's just because, that's how it's distributed in the population. But it was a little bit more common in DM1. But what does that mean clinically? That's still at question. And so if someone of your care team checks this hormone or so, please ask them to help them interpret this specific result for you and for your situation. And particularly if you go IVF or so, that's a conversation you'll have with your doctor. What does this mean? Does it predict anything in your particular case? And now let's look at the flip side of things about the question: are there fertility issues in women with DM1? So the study that I just showed you may suggest that, because again, the anti-Müllerian hormone is supposed to give us an idea of how good the ovaries are in shape. On the other hand, this study, for example, was a study of 54 women with DM1 that had IVF. So 54 women that were affected with DM1, and they underwent IVF. And they had, and so why are we looking at IVF studies? Well, these women are getting hormones that kind of stimulate the ovaries to produce these eggs, like you just heard from Dr. Thornburg. And so the interest here was, is there any difference in this ovarian response when you stimulate them between patients with myotonic dystrophy type 1 or controls that don't have myotonic dystrophy, and there was no difference. The ovaries in this study, they all responded the same way. There was no issue with that. And in fact, the pregnancy rates, so how often was this IVF procedure successful, were similar in people with DM1 than people without DM1. So that study kind of indicated, maybe if they could not show an impact on fertility. And then I'll move on over to Dr. Thornburg, back to Dr. Thornburg.
And I'll just say on that Müllerian hormone and FSH and LH and all of these hormone levels, I would not get these checked routinely as part of like, am I, do I have a lot of eggs left in the basket? Can I delay childbearing? Like, because nobody really knows how to interpret these outside the realm of actually preparing to undergo IVF. So I would not get this level checked and then take it to the bank that means that your ovaries have, X many eggs left. That's not really a thing we can tell you. In fact, you're born with every egg you're ever going to have. You have your maximum number as a 12-week fetus. So everybody's eggs are slowly decreasing as we age. So please don't just run out to your doctor and tell them that we said to check an anti-Müllerian hormone because you want to know if you have eggs left. That's not going to give you the answer you need. It needs to be viewed in a broader context of all the things that you need to know related to your fertility. And then I just wanted to put in this information in case there are people who are looking for it. I know this has been on a lot of people's minds after the election and everything that's been going on post-Dobbs is if pregnancy is not something that is in your future plans and it accidentally occurs, or you find yourself in a situation where you have a very affected pregnancy that is not something that you're interested in taking on, are there options remaining in the United States? And there are. And I wanted to put in some resources of how to find those resources, how to find those options, and how to help get those paid for if that is a concern. And so here are some resources related to that. Would also like to point out that people with physical disabilities get pregnant unexpectedly at a higher rate than people without disabilities. And part of that is related to the fact that doctors aren't as good as remembering to discuss sexuality and contraception because there is a bias and some infantilization of people with disabilities in many offices. So this may be an area if you're parenting a teen with myotonic dystrophy where you may want to think thoughtfully about this. People who have disabilities of any kind have sexual debut, which is a fancy way of saying their first sexual encounter, at the same ages as people who do not. So do not expect that just because your teen has insert whatever medical disease here, that they're going to choose to engage in these things later than other children. They, in fact, do things the same as their peers. So no time like the present to discuss that.
Yep. So let's talk a little bit about before the pregnancy. I can only emphasize the importance of genetic counseling. I know you have heard and read a lot about myotonic dystrophy, but it doesn't hurt to talk to a genetic counselor in clinic or to your myotonic dystrophy specialist. Specifically in the setting of planning a family or pregnancy. Here we'll just revisit the basics. So the inheritance pattern in both types of myotonic dystrophy is autosomal dominant, and that means that there's a 50-50 chance of passing on myotonic dystrophy to a child. This 50-50 chance is like flipping a coin, and it is the same for each child. So if you had one child with myotonic dystrophy, it's again 50-50 with the next, again 50-50 with the next. And so that's important to keep in mind, and that's true for both diseases. Now, in DM1 in particular, there is this other concept that you already heard about, anticipation, where the disease has a tendency to get worse or more severe from generation to generation. And so this you see kind of depicted in this picture where grandma isn't as affected. You might not even be able to tell that she has a muscle disease, but then her daughter is a little more affected. And then her daughter has a child that has the most severe form of myotonic dystrophy, which means that children have symptoms in utero and then visible at birth. So that's the congenital myotonic dystrophy, which is still, again, DM1, but it's the most severe form. And so that is to keep in mind when we do genetic counseling and talk to families in the clinic. Now, I want to move on to what happens during pregnancy to the woman's body in general, so unrelated to myotonic dystrophy, because that's important when we think about, well, what are you getting ready for? And also, what's normal? What is done every day all over the world by so many women all the time, because it's normal and physiologic. And that is that, for example, with pregnancy, the blood volume increases by about 45%. So there's more blood circulating. That means the heart has to work a little harder and push out and pump out a little more. And the heart rate increases as well. That's a normal change in pregnancy. Another normal change in pregnancy is that the volume that fits into your lungs, depicted here in this orange, dark and light orange, that's the volume of the air that fits into your lungs. As we move on here, this is the other months of the pregnancy. As we move on, there's a little drop up to 20% maximum, but there's a little drop, and you can imagine that to happen for many reasons, but also just because all of a sudden you carry a lot of weight right beneath your diaphragm. And so the lung volumes decrease. And then women get more short of breath. As they move on with their pregnancy, people can get more short of breath. That's normal too. That's not data from myotonic dystrophy. That's just anyone with pregnancy. Now, the other common symptom is that the hormones change kind of how the consistency of the muscles. And also because you have so much blood volume, it's normal to go to the bathroom more often, to have to get up at night to go to the bathroom to urinate. And so there can also be stress incontinence specifically, which means that when you cough, for example, that you leak a little bit of urine, particularly when there's weakness of the pelvic floor. And so that's normal in particularly with more than one pregnancy. So this is normal in the general population as well. Moving on to GI. So one of the hormones that peaks and gets a little higher in pregnancy, progesterone, that reduces smooth muscle contractility. So it reduces how the smooth muscle contracts and squeezes. And that's, of course, of impact for the GI system. So women that are pregnant can have more acid reflux, more nausea, and then also constipation. And I don't have to move on to the next slides to tell you that may have an impact, because those areas can be affected in women with myotonic dystrophy. And so when we put this all together, kind of what changes you can expect with pregnancy that are normal and that are dealt with every day, you will notice that some of these overlap with the multi-system organ manifestations related to myotonic dystrophy, because as you know, myotonic dystrophy affects the muscle, yes, and causes muscle weakness and stiffness, but it can again, affect other organ systems such as the heart, not so often the pumping function, but the heart rhythm. It can affect the GI system, as you know, and cause constipation or diarrhea or both. It can cause GERD. And then also difficulty breathing at times. And so I want to highlight also the effects on the brain. Again, variably, people can have excessive daytime sleepiness. Some people just need more sleep than people without myotonic dystrophy, and that is that is something to consider when you plan a pregnancy. You might get up more often at night to go to the bathroom, or when you have a baby, sleep deprivation is something that most caregivers have after a newborn is born. So those things to consider. It doesn't mean it's impossible or it should be discouraged. This is not the message here at all. It's just we want to help to plan ahead and make this a good experience, and to make sure you get the best care and the best counseling there is to move on this path. And with that, I'll move over to this slide, which kind of shows you what, and I recognize that not everyone lives in an area where you have access to all these services. But there are capabilities, resources that you may ask for. And also, if you don't ask about, building your team, it may not be offered because a lot of people aren't familiar with myotonic dystrophy and what you need. So you are the educator of your community physicians. And so what do you need? Well, you need a whole team, and your team might be bigger during pregnancy than you usually need because you may otherwise, be doing fairly well. But during the pregnancy, you need a whole team, and that includes your OBGYN, your neurologist. You may think about, again, the genetic counseling piece, a pulmonologist if needed, a cardiologist definitely, anesthesiology, we'll get to that, PTOT, and we'll get to that a little bit too, and lactation specialist. And and then I'll move on to give it over to Dr. Thornburg.
So coming back to that multidisciplinary team, just to double back on that, one pro of the pandemic, I guess, has been that, there has been a great big expansion in access to things that you can get by telemed and you can get by remote care. And, there is now remote lactation services. There's a lot of these things that can be done by non-synchronous or even remote services, including a lot of that specialist care. And one of those places you can get care is something called an MFM specialist. Now, ideally, a patient with myotonic dystrophy would be seeing an MFM specialist during their pregnancy. But I know that not everyone lives in a place where there's an MFM specialist around the corner that they can see. The good news is that almost every place has the ability to get an MFM on a video consult or in consultation with them to get help. And this is the Society for Maternal Fetal Medicine has great resources about what an MFM is and how to find MFM physicians in your area. And people who have complex medical diseases, having an MFM on your team to help wrangle that complex care team can be very, very helpful to help people understand that the physiology of pregnancy is going to both affect the care needs, and the care needs are going to affect the physiology of pregnancy. And so we need to think about the whole dyad when we think about what we're going to be doing. So make sure that you've got access to one on your team if you're thinking about pregnancy. Okay, so when you think about your team, this is why you should be thinking about an MFM. You want to find who's going to be the team lead. Is that going to be your obstetrician? Is that going to be your neurologist? I don't want to throw my neurology friends under the bus, but most of them do not want to come in at 2 a.m. and deliver the baby. So this is where your MFM specialist might be somebody to have on your team, because that is going to be the kind of person who is an obstetrician with additional specialist in high-risk pregnancy care, who's going to be the kind of person who, when things change acutely during labor and delivery, is going to be the kind of person that your team is going to need if things change acutely. But they're going to need to know who to reach out to in neuromuscular, who to reach out to in anesthesia, who is comfortable to manage this. And so you're going to need to have team leads to make sure that you've got a robust team surrounding you. Before the pregnancy, like we've said a number of times, is that because of the variability in your symptoms and how you might be feeling, or in your family member symptoms, preparing for pregnancy, so seeing an MFM specialist beforehand, working with your neuromuscular team beforehand is going to be critical, because depending on which one of these things or any of these things that you experience, making sure that you've got these things optimized as much as possible is going to be key, right? So if you are somebody who has cardiac manifestations of arrhythmia and you can get those under control with either medications or with pacemaker or whatever you need, having that under control before pregnancy is going to be critical if we're then asking the heart to take on double work during that pregnancy. So we want to get this stuff as optimized as we can before we go into pregnancy, not once pregnancy is established. So this is where an MFM specialist can help point out places where we can get things ready to take on that marathon that we're asking your body to do for the 10 months of pregnancy.
And then most of these things here are actually part of the care guidelines. So you should be having them anyway as your usual care. But we all know that it doesn't always happen. So now is the time before planning a pregnancy to do it. And so if you had excessive daytime sleepiness and people have told you should get a sleep study, or they may not have told you, but then ask about whether you should get a sleep study. Yes, now is the time to get a sleep study, because if you do have untreated sleep apnea, it's better treated before, you add a baby to your body. And then the other thing, pulmonary function testing, we talked about the impact on the breathing. So knowing where you're at, and even if things check out fine, that's great. But more data in that scenario, in that situation, is better.
Pulmonary and cardiac wise, pregnancy is the stress test on the body, right? You're asking it to double its work volume. So we really want to know that we've optimized those systems, especially cardiac and pulmonary, before we go in. And I mean, maybe some other people live in different places, but where I am, you're not going to get a sleep study because you ask for one today. That could be several months of planning. So, you want to plan ahead on these things.
So here we have a table showing you some of the complications that can occur during a pregnancy, and it's DM1 in red and DM2 in blue. And again, keep the limitations of the information in mind, because those are studies that were retrospective, looking back, or survey-based, etc. And not a lot of them were not done in the United States, and so care differs also. So one thing also to keep in mind, it matters whether a woman with DM1 has an infant that's affected, and congenital myotonic dystrophy is symptomatic before birth, because the children, for example, aren't swallowing as much, so then there's too much fluid, what we call polyhydramnios. And so it matters if a woman carries a baby that's affected or not, in terms of what she may encounter throughout her pregnancy. So I'll pass it on to Dr. Thornburg in just a moment, but I'll just say something about symptom onset or worsening. So there is variable information in the literature. Some studies show that yes, people reported worsening of symptoms, or even had their first symptom of myotonic dystrophy as a pregnant woman. So for example, they noted myotonia during pregnancy, and then it went away again after the pregnancy, and then it came back later in life, or something like that. I have heard that, and that is in the literature as well. But how does it, I know we had questions, how does it really impact this trajectory of the disease? Is this going to be a negative predictor? Am I going to do worse because I had a child? We don't have the answers to that. So that would be, we can't answer that. But there's variable information whether people do feel worse or worsening of symptoms. One is myotonia, weakness, but you also learned the physiological changes to the body during the pregnancy. So, feeling more short of breath, for example, you can put into context, because some of that is physiologic or exacerbated because of myotonic dystrophy, but again, physiologic changes. So I'll move, pass it on.
It's also really hard to sort out, like, for example, like fatigue. Do you feel more fatigued now that you've had your children, right? I don't have myotonic dystrophy. I have 2 children. I am definitely more fatigued now that I had my children. I don't know that that has anything to do with the fact other than children are a lot of work, right? So it's hard to sort out how much is from disease and how much is simply caring for an infant is a lot of work. So it's very challenging to sort those things out. I will point out on this, as Dr. Hamel was pointing out, the polyhydramnios, the preterm delivery, the instrumented delivery, the non-vertex presentation, and the hemorrhage are all directly related to having an affected child, because those overdistend the uterus. The infants don't move as well. They don't get into position as well. They don't come down through the pelvis as well. That cesarean rate is related to that as well. So it's hard to take each of these numbers in isolation, because if we pulled out those 14 children that had congenital DM, we would find a very different result in this group. But I want to draw your attention to, there's a slightly higher miscarriage rate, there is a slightly higher placenta previa rate, and a slightly higher ectopic rate. And those do seem to be real in the population. across several studies, as well as the higher UTI rates. And so these are the kind of things that your general OBGYN may not be aware of, but you should be, and you should be reminding them that I'm not the same as other people. These are the things that need to be watched for a little more carefully in me because I have a slightly higher risk. That doesn't mean it's going to happen. It just means that you may need a little more vigilance.
And to highlight DM2, so the increased frequency of UTIs was also notable in DM2, while a lot of the other things that you see here can be at times comparable to the general population, but UTIs definitely was the case as well. And then here you see successful deliveries, and Dr. Thornburg mentioned miscarriages, but this was also a study looking at births in DM1 and in DM2. And there was here, these are ectopic pregnancy and then miscarriages. This is the in percent, over just about 80% had very successful pregnancies to the end, and there was a higher rate of miscarriages.
Remembering that the miscarriage rate in the population is somewhere between 10 and 20%, depending on how you count it. So it's not that far off the national rate. So this is just looking at kind of the too long didn't read portion of this slide. Can you click one more time so just that last box pops up? Is what doesn't change, what might change, and what definitely changes across DM1, just so that you kind of have the summary slide of what to kind of keep an eye out for.
And then just to give you an idea, again, from a different angle, so looking at this study that looked at this cohort, 54 women with DM1 who had IVF, they had 31 births. And so they looked at, was there any difference between the women with DM1 and their pregnancy outcome versus women without DM1, and there was no difference, and no newborn died because the children didn't have myotonic dystrophy, so there wasn't a congenital case, of course. But that, that sometimes it's helpful to look at different studies, studying, because then you can remove the impact of the congenital myotonic dystrophy child carried by a woman, if you look at these studies that way. And so during the pregnancy, we kind of elaborated that, but really monitoring for symptoms, monitoring for the infections, for the UTIs that we highlighted, and then early anesthesia consult to get people acquainted with your disease and with your needs. And if problems occur, again, having your cardiologist on board and making sure your breathing function remains stable and your swallowing as well is important throughout the pregnancy.
And then this is just reminding you that through the trimesters are going to affect kind of what you're focused on. Trimester 0 beforehand, we want to make sure that people are thinking about medications and optimizing their optimizing before pregnancy, all their medical conditions. During pregnancy, we're coordinating care, thinking about anesthesia, thinking about delivery planning, and then afterwards thinking about recovery, mental health, spacing pregnancies, and thinking about, again, making sure we're thinking about that preconception space based on what happened in the current pregnancy. And just a quick note about, next one, just a quick note about medications, and we won't belabor this point, but people with myotonic dystrophy are very sensitive to anesthesia if you've ever had anesthesia. And so just be really thoughtful about reminding your anesthetic team that hypersensitivity to depolarizing muscle agents is very common. And so if you were to need general anesthesia, which is very uncommon in obstetric patients, most people use epidurals or spinals, that they should be aware of your disease, and your chart may need to be noted, or you may need wristband to note that you are a patient who should not receive depolarizing agents. Postpartum, you should advocate for a longer length of stay, additional support from the lactation team. Every hospital in America has a lactation team as part of your support network. If there was not pre-implantation assessment or an assessment of neonatal effects, you probably want your infant assessed. That people who have functional limitations are at increased risk for postpartum depression and for postpartum blues, and follow up with your doctor within the first couple weeks postpartum is important. you're going to want some help thinking about how you're going to do functional tasks. And do you need help with PT, OT, or lactation? Do you need help with specialized equipment at home or things to help with infant care? And there are a lot of great places out there that help do this. And if your partner has physical limitations or has other things that they need, are you making sure that you're getting rooms and spaces that work for both of you to be able to co-parent during your hospital stay? So you're going to want to make sure that your care team is working with the nursing team, who often helps to arrange room considerations as you're planning for your delivery. This is a great website. It's actually for people with spinal cord injury, so don't be put off by that. But there's a section of it that's parent to parent. I made this to help me parent with whatever adaptive technology I use. And I made this thing where I strapped this thing to that thing using zip ties and duct tape. And now I have this walker that also holds my baby while I cook and does this thing. Or how do I cross the street while I don't make sure my kid doesn't let go of my wheelchair? Whatever. They've got a million different suggestions of things that they've done. And it's really incredibly inventive, the things that people have come up with. And it's kind of the MacGyver of parenting hacks for people who use assistive devices. So somebody's thought of it. It might be on this website if you're looking for something.
Yeah, and so we will close out here with more questions. So for example, the question we had quite a while ago was, how does DM impact menstrual and sexual health? And we put out a survey. So thanks to everyone for answering it. It is now closed. It's with a statistician. They're looking at your answers, and we're hoping to get it back to the community, the results and what we found out. But definitely, the smooth muscle is affected. There's way more to women's health than just having babies and family planning. There's so much to that. And so hopefully we'll get some more answers. Also hormonal effects on DM symptoms. For example, GI, how does it change with the menstrual cycle, et cetera? Not studied. Bladder function, not well studied. Some information in the literature, but not enough. And then menopause, not enough information. And then we also need better studies on pregnancy outcomes. And now you heard earlier, but we're entering a new era where we will have targeted therapeutics in the clinic. And so what does that do? Pregnancy outcomes in that area, and how to manage that, and how to juggle the drugs in the future in the clinic for women planning a pregnancy. All of that lies in the future, and we're trying to prepare. And then one thing I would just like to add at the end is also exercise, because I failed to mention it earlier. So as you heard, the pregnancy is kind of the stress test for the body. You can prepare. We know exercise is beneficial for people with both types of myotonic dystrophy, and it needs to be individualized. But the better you get your body in shape, the better you can also maintain that fitness during the pregnancy, because it's not recommended to all of a sudden start this, exercise workout that you've never done before when you're just pregnant. So again, something to discuss with your doctors, because exercise recommendations are routine in our myotonic dystrophy clinic, in particular when you plan a pregnancy. And I think that was the one thing I'd forgotten to comment on. And with that, Dr. Thornburg, did you have any other?
No, I think that, I think one thing to keep in mind is that there's so much bias in this area, and please don't accept the answer, well, you can't have a baby at face value. Please, it may be that that's true, but most of the time it's not. So please reach out, please ask for a consult, please ask for opinions, and make sure that that's coming from a place of education, not from a place of fear and bias. Because most people with these conditions, or a variety of other neuromuscular conditions, actually can successfully carry children, can successfully father or parent children, and can parent children in a variety of ways. So if that is part of what they want to do. So please keep that in mind.
Wonderful. Thank you for that informative presentation, Drs. Hamel and Thornburg. We will now transition to the Q&A portion of today's webinar. As a reminder, we do ask that you use the Q&A function to ask your questions, and they'll be sent directly to our experts. We will do our best to answer as many questions as we can. To ask questions, click the Q&A button and type your question into the text field, and then click send. You can also send questions anonymously if you prefer. So we will now open the floor for questions from our attendees, and I will start off with some questions that were submitted by folks upon registration. So someone asked, is it safe to have a child via natural childbirth?
So the short answer is maybe. Yes, generally. I think they mean vaginal delivery, right? So like all childbirth is natural. There is no wrong way to birth a child, right? It is best that your particular situation be evaluated by your care providers, right? So the answer is no. If you have a placenta previa or a baby that's in a bad position, or a baby that's not tolerating labor, then the answer is no. If the answer is you have a baby that's in the right position and tolerating labor and you are otherwise a good candidate, then yes, the answer is that's actually the safest choice for you and baby, the lowest risk of bleeding, the lowest risk of complications. So the answer is it depends, I guess, but in general, people with neuromuscular disorders can birth vaginally without concern. For the most part, there are a few collagen disorders that can change that equation, but in general, in this group, we would recommend vaginal delivery.
Great, thank you. Very helpful. Someone else asked, is my history of huge uterine fibroids connected to DM?
No. So uterine fibroids are smooth muscle. We call them tumors, but they're not cancerous. But as we age, there are little balls of uterine muscle that choose to, instead of being long and thin and aligned with the uterus, choose to form a little nest of uterine muscle. They're nothing you cause, they're nothing you do. We know they happen more as you age. We know they happen more in people of certain ethnicities. They sometimes just happen. They love hormones. They love estrogen and progesterone. So when you're pregnant, they will grow bigger and they will shrink back afterwards, but they are not related, as far as we know, to any particular neuromuscular disorder.
Great, thank you. Very helpful. Someone else asked, they stated that they had a 58-hour labor with contractions starting at 5 minutes apart. They didn't dilate until they resorted to morphine. Could this be cervix myotonia?
So it's hard to know. First labors especially can be very long. There is such a thing we call prodromal or protracted early labor, and it sounds like something that this patient was experiencing, or this person, where you're not dilating, but you're contracting, and it's super annoying. And sometimes what we call therapeutic rest, which is where you give somebody medication for pain, like morphine, and you essentially tell the body and the uterus to do, it's kind of the turn it off and turn it back on again of the body, and say, everybody needs to take a nap, and when you wake up, maybe you'll be in labor, and that sometimes works. So that sounds like maybe what happened. But, we know that this is a concern for, is a muscle disorder, right? So there's some potential reason why we might think that labor could be protracted in people with myotonic dystrophy. We don't really know, right? The best data we have suggests that there may be some increased risk of hemorrhage, but that appears to be more related to babies that were too big and malpositioned and the kids that were congenitally affected. But we don't know that that's purely related to that. That also could be that the uterine squeeze was not as good as we would have liked either. So is there a little bit of a role that the uterus doesn't squeeze as much as we would like? And that's why we ask the question, about menstrual symptoms and things like that, because we wanted to know if maybe the uterine muscle is more affected and menstrual symptoms are more common in this population than in people without myotonic dystrophy. And so is that something that, has just been kind of like not asked? And so we don't really know, but it's probably not related to that. But I really don't know this particular person.
Yeah, that makes sense. Thanks.
Mm-hmm.
Someone else
to add on just one quick comment. So yes, myotonia, we know a lot, not all of it, but how it happens in skeletal muscles or striated muscles or in the hands and the limbs, but we don't know exactly much about the smooth muscle. For example, is smooth muscle capable of generating myotonia, the delayed relaxation of the muscle? Is it happening in the GI system? That all isn't really well known. So to your point, is it in the cervix? We don't know.
And the cervix is a funny organ, right? Because it gets wide open and then it has to close all the way up and stay closed again. And then it has to get wide open again on demand and then close up and then not open when it shouldn't be open. I mean, it's kind of a crazy idea that you have this thing that can, dilate when you need it open and close when you don't need it, and knows when it should be open and knows when it should be closed and keep a kiddo cooking when it should be cooking and not cooking when it should come out. I mean, it's a very smart organ, for lack of a better term. So it's impressive that it ever does it right. So we don't really know why it is able to do that. I mean, it's a collagen-based organ, though, not a muscle-based organ. So it would be surprising to me if it had myotonia, because it's more collagen than it is muscle.
Interesting. Okay, that's good to know. Someone else asks
what it feels like if you were to touch it.
Okay, yeah. It's a good comparison. This person says, in both my pregnancies, I had placenta previa. Do we know what causes this in myotonic dystrophy, and is there anything we can do to reduce the risk of having it?
So no and no, but we think it has to do with this. Again, is there something we don't know, as Dr. Hamel was saying, about smooth muscle and how these things happen, right? Because we know a big part of why the embryo chooses a location in the uterus. The egg and the sperm, actually, if you get pregnant on your own, get together in the fallopian tube. That's where they meet and make a little embryo. And then they come down into the uterus and they pick a spot in the uterus to embed. And they should pick a spot up near the top. If you have a previa, then they've picked a spot down near the bottom to build their home. And why sometimes the embryo picks a not great spot, we don't know. We know that people who have scarring in that area, for example, people who've had lots of C-sections, embryos tend to pick more commonly, which is very annoying because it can cause all sorts of other problems. But we do know that people with myotonic dystrophy, their embryos tend to pick lower more often. So whether that's a myotonia issue, whether that's a smooth muscle issue, we don't know why that is, but it definitely is true. But it's, again, to come back, this is nothing a person can cause or do. This isn't because you didn't lay down enough or you ran too much or you made your embryo fall down. This is nothing anybody can affect or personally do.
Yeah, thanks for clarifying that. That makes sense. Someone else asks if there is any information about using Nexplanon in someone with DM1 to prevent pregnancy.
Nexplanon is a progesterone-based contraception. It looks like a little, it's a little tiny rod, about the length of a top of a pen, but it's very, very thin. And you put it underneath the skin under your arm. It slides under the skin and it's good for about 3 years and it prevents pregnancy. It's progesterone only. Progesterone only methods have the advantage of often stopping periods or making periods very light. Nexplanon, it takes a little longer for it to do that by itself than IUDs do, but it has the advantage of you don't have to have anything in your uterus. So if that kind of weirds you out, you don't have to do that. It's right up here in your arm. You can feel it. You can have it taken out whenever you want. They're very well tolerated. They have a very low side effect profile. They don't have any risk of blood clotting compared to things like the pill, where we talk about estrogen and progesterone having a combination effect of blood clot issues. So there is not specific data for people with myotonic dystrophy, but there is very good data for, in general, menstrual suppression for people with immobility and other reasons, and it is a very well tolerated type of contraception. And it's nice because it's nothing you have to think about every day, which is really one of the best parts about it.
Yeah, definitely. That's great. Someone else asks, if I'm already having significant cramping in my lower abdomen, will I likely have issues with pregnancy?
No, but the cramping may be something, that could be improved with medications or with care. And so it may be that they have something else, whether that's the fibroids like someone else was talking about, or endometriosis, or, any of the other things that people can get that cause discomfort in their pelvis can also happen. So I would recommend that they follow up with their OBGYN, because there's no reason to just blame their myotonia. They can get therapies and other care to improve that even before pregnancy.
Yeah, that's great. Okay, we'll just answer maybe 2 more questions before we wrap things up. Someone asks about how common is adenoid meiosis, don't know if I'm saying that right, in DM1, and what, if any, treatment would be recommended?
Adenomyosis is the lining of the uterus is called the endometrium. And if you have little nests of endometrium that, instead of being confined to the lining, have worked their way out into the muscle wall, because the muscle wall of the uterus is sheets of muscle oriented every other, so that they can make a nice squeeze when we have our menstrual cycle or when we need to have a baby. And those have spaces between them. So if little nests of endometrium get out there, they can make a little spot where they shouldn't be. And that's what adenomyosis is. And because that blood can build up in there, it can be painful, right? Anytime you have a bruise inside of a muscle, it's uncomfortable. It is not more common in anything other than as we age. That's another one of those, like, great, love having birthdays. It's just more common as we age. It's more common as we have more children. It is not anything that we think is related to any specific disorders that we know of. The symptoms of it can be improved with hormonal contraceptives to quiet that endometrium and to make it stop producing so much blood and so much hormone, so that it stops annoying the muscle around it.
Great. Thank you. Okay, we'll end with this question. And I know you both kind of talked to this subject throughout your presentation, but maybe just to kind of solidify the answer to this, does getting pregnant with myotonic dystrophy cause your disease to progress? If yes, is it short-term or long-term?
You want to take this one?
Yeah. The answer is we don't, or there is no clear answer to that, but I can provide a little bit of background. So first of all, when we study disease severity and we look at different people who experience different symptoms in their disease, we always look at sex effects, meaning does it make an impact if you're female or male? And there is a little bit of controversy out there, but oftentimes in many studies, we did not find a sex effect. So the disease kind of caused the similar course and symptoms, no matter if you're a woman or a man. And so that would argue against that, because a lot of women with myotonic dystrophy have children. So, to my knowledge, there hasn't been proof that having children speeds up the disease or has a negative impact on people's lives in terms of disease progression. Again, if there is worsening of symptoms like myotonia flares up or so, again, that oftentimes improves after the pregnancy. The studies we reviewed didn't show that there was in some other neuromuscular diseases, there is actually reports that people feel like they're worse and they continue to be worse and they don't get better after if they had worsening of their symptoms during pregnancy. That is not so typical for myotonic dystrophy. So in my experience at this point in time, what we know, I would not discourage a woman to have a baby if safe for all these other reasons. For the concern whether that's having a negative impact on her life with myotonic dystrophy in terms of, biologically altering the course of the disease. I don't think there's evidence to support that claim.
And I think it's hard because people who have progression of their disease are always looking for like that inflection point of when did it get worse. Right. And so it's easy to like think back on life events as things that are easy to remember, like before this, things were easier, before that, things were easier. Like you think about like, you can remember your life pre-pandemic and post-pandemic, right? But can you remember your life pre some random event in your life? Probably not. So it's easy to use things like birth of your children as like pivot points of like when things were better or worse. And like I said, raising children is a ton of work. So it's easy to think that there's some mix of that data there. I mean, I think if parenting is an important part of your journey, then I don't think there's distinct data that says this is a terrible plan and it's like you're going to shorten your lifespan by a significant amount if you do this. There's probably some pros and cons to parenting, just like there's pros and cons to everything in life, but there's not data that this is a, slam dunk problem that if you want to do it, I think the data suggests that it's a thing that people can do very safely if they want to.
Yeah, thank you. Thank you both. That's great. I will wrap things up just by thanking all of our attendees for their participation. And again, thank you to Drs. Hamel and Thornburg for providing this Ask the Expert webinar. As a reminder, this webinar is being recorded and will be sent out within the next week. After the webinar ends, you'll be provided with an option to take a short survey about today's program, and we would greatly appreciate you taking the time to provide us with feedback. Lastly, if this program spoke to you, please consider showing your appreciation by making a donation via our website. You can also get involved by joining the Myotonic Dystrophy Family Registry. Thank you all for joining today's webinar, and we'll see you next time.